with the kids.
Now.
Great. Hi, everyone. Welcome to the second session of our first Pregnancy and Liver Disease series presented by the American Liver Foundation. My name is Alice Rhoton-Vlasak. I'm one of the co-chairs of this series, along with Dr. Genc. And we're very excited to have you join us today. The mission of the American Liver Foundation is to promote education, advocacy, support services, and research for the prevention, treatment, and cure of liver disease. You can find out more about their professional programming, such as upcoming programs like Update on Liver Transplantation and Health Disparities in Liver Disease, with a focus on women's health, on their website at www.liverfoundation.org. Requests for credit will be available beginning tomorrow, Friday, June 25th, and you've received an email on the steps to requesting credit. Now, before we get started, I would like to introduce Ivory Allison, the National Manager, Outreach and Education for the American Liver Foundation, to review the housekeeping rules.
Good evening, everyone. I just want everyone to be aware that we are recording this session. It will be uploaded on our YouTube channel for you to further review. We will have a Q&A session after each topic, and you can ask questions in our Q&A section or our comment section. There is a disclaimer posted here, again, to let you all know that this will be recorded and uploaded on our YouTube channel. Thank you. I'll turn it back over to Dr. Zori.
Well, I won't cut into too much of our speakers' times. We've got 3 topics for you today. The first topic is contraception and liver disease. This will be presented by Dr. Alice Rhoton-Vlasak.
So let me get my screen up here. Okay, can everyone hear me okay? Okay. So thank you for inviting me to be part of this session. So actually, unlike the other people at the meeting, I am not a liver specialist and I am not a maternal fetal medicine specialist, but I'm actually someone who helps people get pregnant, but also thinks about contraception, because many of my patients that I help get pregnant come back to see me for contraception after we're done helping them have babies. And so the purpose of my section is to talk a little bit more about what we can do to prevent this from happening, which is getting a sperm to fertilize an egg. So that's what I'm going to be reviewing tonight. I'm not going to talk about any off-label uses of drugs, and I have no disclosures. And my learning objectives will be to review what are current contraceptive options that are available. I don't know if you know, but if not, to highlight the excellent available online CDC medical eligibility criteria for contraceptive use, which is a guideline that I use even every day to look up if this patient has acute liver disease, what are the options that would be safe and medically appropriate, and pretty much follow their guidelines in conversation with the patient. Then on the other hand, to explore what are some liver-related risks of contraception with one clinical case, and then to navigate just in really a diagram, the contraceptives that would be reasonable in women of reproductive age with liver disease. And so I want to start, interestingly enough, when I got asked to give this talk, I thought, well, I'll start with my own case presentation, me as the patient. So when I was a fellow at the Mayo Clinic in Rochester, everyone that goes there as part of their first intake to be working in the Mayo Clinic has to go for a physical exam and lab work. And so I got there in 1996. I was a really tired new mother, breastfeeding, exhausted. My son had a lot of complications after he was born and had to have surgery. So I figured I was a tired mother, breastfeeding fellow, no big deal, I'm going to live. So I got my labs, my liver enzymes were up in the 200s. And so I was on oral contraceptive pills for birth control. They said, you know, it's probably from your birth control pills. You just stop your pills. Don't worry. You'll come back in 2 weeks and everything's going to be fine. And so I stopped my birth control pills in 2 weeks or 3, I can't remember, 2 to 4 weeks. I went back. And by that point, my liver enzymes were in the thousands. And so at that point, it wasn't okay. It turned out that looking back, I had this really weird rash when I was pregnant. Nobody ever knew what it was. It wasn't diagnosed as anything. But the bottom line is I underwent a liver biopsy. I found out I had autoimmune hepatitis. I'm an autoimmune, like, potpourri of everything you can think of. I went on treatment with, you know, steroids and Imuran. And then within a month or 6 weeks, 2 months, I had a, you know, normalized liver enzymes, repeat liver biopsy was negative. And so the point of bringing it up is, number one, I'm a clinical case for this lecture, but I think you have to realize that if somebody isn't feeling good on their contraceptives, other things can come up. It doesn't mean it's from the pill, but that, you know, I did get better, but it wasn't just from stopping my contraception. And then I basically been in remission. My son is 27, so for 27 years. So it's a good story. So currently, what are the options that are available for women to use for birth control? So very commonly now, women will get either a copper IUD or a hormonal IUD, primarily progesterone, or more permanent. It's permanent. It's highly effective but reversible. Or they could get a sterilization, such as a vasectomy or tubal. Other options that are more, you know, probably very common, IUDs are very common, a combination or progestin only pill, a combination vaginal ring, a combination patch, a progesterone shot, and then other types of barrier methods. And so there's also always, you should remember, emergency contraception as well. And then there's 2 or 3 new things that I didn't even know about. You know, one of them is Phexxi. I don't know if any of you have used that, Dr. Genc or Dr. Gregg, but it's a vaginal gel that keeps the vagina acidic so sperm are unable to survive. And it's a new non-hormonal type of barrier contraceptive. There's a new vaginal ring that's good for, you know, use over 1 year. And there's multiple progesterone IUDs that are good for 3 to 7 years. So with those type of options in mind, then when you think about someone with liver disease, it could be gallstones, it could be hepatitis, viral or non-viral, it could be cirrhosis, liver transplant, hepatic tumor. Then I would want to know, if I were a liver specialist and I'm seeing a 26-year-old with hepatitis, for example, what would her options be for contraception? So among those choices, you can use these medical eligibility criteria, which there's also an app that you can download from the CDC website onto your phone. And that's how I use it. And it's to help assist healthcare providers when they counsel patients about contraception, and it's made from evidence-based guidelines with over 120 conditions and subconditions. And so again, what they consider is, you know, a variety of options, but most of the ones that they really outline the risks and benefits have to do with intrauterine devices, progestin-only contraceptives, combined hormonal pills, and then and then the implants, which are progestin only. And so there's several categories of use for these that they rate on a scale from 1 to 4. And so, I mean, 1 means it's safe and there's no restriction, no considerations. They could absolutely use it. In category 2, if the benefits outweigh the risk, it's an option you would discuss with the patient and still consider. In category 3, usually it's not going to be necessarily recommended unless more appropriate methods are not available, and you would do it only when you really counsel the patient and make a well-informed risk-benefit decision. And then category 4 is unacceptable. So yesterday I was in clinic with a woman who had poorly controlled hypertension, 38, obese, type 2 diabetes. She was on oral contraceptive pills. And so we looked up together, you know, and actually for uncontrolled hypertension with diabetes, it's also poorly controlled, and obesity, oral contraceptive pills are unacceptable because there's other safer options. And we looked it up together so she could see, and we both felt good about the decision we were making. So I just want to point out some, and I'm not going to go through obviously everything on this list, but for hepatologists that are, or even OBGYNs that might see patients with liver disease, for example, under liver tumors, you can see with hepatocellular adenoma, a copper IUD is a category 1. And then anything really containing hormones is considered category 3, and combined birth controls are category 4. So you wouldn't use those because there may actually be a link between the estrogen in birth control pills over a long time and the development of hepatic adenoma. With viral hepatitis, you can go through down here and see, you know, the copper IUD is category 1, the progestin IUD is category 1, and so on from there. The same if you had a patient with lupus and liver disease. And then the other categories they cover is mild and severe cirrhosis. For mild, almost every option is a category 1, whereas with severe liver disease, only really a copper IUD is considered without additional risk. Then gallbladder disease and a history of cholestasis in pregnancy, or also if you had a patient, which is what they thought I had originally, was cholestasis from my birth control pills, which can typically happen, but that didn't turn out to be the case. But if they had that in the past or during pregnancy, they get a different consideration. And so there's also from one, you know, this is from the same area of that CDC website where they highlight in specific just for women with liver disease as a quick guide to options for which you can counsel your patient and what each category means for that patient. And then I just put this up just so you can see. I find this extremely useful. It's downloaded on my phone, and refer to this very frequently if I'm not sure or I want to double check the safety in my particular patient with her particular medical condition. And then the other side of the coin is, what about the risk to the liver of being on a contraceptive? And so in general, when we think about contraceptives that can affect the liver, the primary form is anything that would contain estrogen, like ethinyl estradiol, and it doesn't really matter on the route. So what things have ethinyl estradiol as their contraception with a progesterone? It's the patch, and it's the vaginal rings, and then it's different forms of combination contraceptive pills. And if they had mild liver disease, that might be a consideration. But with severe or acute liver disease, you would not use this because the estrogen is metabolized in the liver and may have an impact on liver function or the disease. We would stop them with hepatic adenoma. I had one patient that had been on birth control pills for many years. After she finished having all her children, she wanted a tubal ligation. And we did her tubal. At the time of the tubal, we always look up at the liver. She never had any symptoms at all, but she had like a 6 centimeter hepatic adenoma that we found that eventually ended up requiring surgery. If somebody had Budd-Chiari malformation or a venous thrombosis in their veins related to the liver, hepatocellular carcinoma, or acute hepatitis, we would not want them on an estrogen-containing contraceptive because this may worsen their disease. And so in some women, they also develop cholestatic liver injury. And so, the case would be that they start the pill, within a few weeks, they start getting itching and other symptoms. You get lab work, it shows abnormal liver tests, elevated potentially bile acids. They stop the pill and then gradually get better, usually having a benign course, but sometimes even off the pill, this can be more protracted. The use has also been linked to benign and malignant hepatic tumors with a low risk of 0.5% per year of use. It's quite low, and it's more common for adenomas like this, a solitary benign thing. Some of those can be followed. Some might need surgery. Some might present with an acute pain, bleeding problem and need surgery. And then other reasons you wouldn't want to, or other potential risks are Budd-Chiari syndrome, dilation of the sinusoids in the liver, and potentially a slight increased risk of gallbladder disease. So that's the other side of it. What are some things that someone might not have had that some type of estrogen-containing contraceptive may contribute to or cause that should be on the index of suspicion if somebody came in with new symptoms? And so probably most of you know a hepatic adenoma is a benign growth in the liver. It can be associated with oral contraceptives and have a benign presentation where it just gets followed, or it may end up needing surgical resection. And obviously, if it presented acutely with bleeding, that would be an emergency. And so on the other side of things, there are hormonal contraceptives that are progesterone only that could be considered in acute hepatitis, flares of hepatitis, mild liver disease, and mild cirrhosis. In more severe liver disease, even though they don't have estrogen, since the data for safety of progesterones and estrogens is mostly extrapolated from combination methods. Progestin-only methods are generally not recommended, but you might decide that's the best option. And this would include the possibility of pills, implants like the Nexplanon, a Depo-Provera shot, or the progesterone IUDs. And so what about in liver transplantation? So typically, if they're doing well after a transplantation, you could consider progestin-only methods, although there is some theoretical concern that some of the medicines that they would be taking to prevent a transplant rejection or other type of antiretroviral drugs may increase the metabolism, so they're not as effective. With IUDs, there is some theoretical concern that if their immune system is lower due to the post-transplant drugs, this could be an issue. But even in HIV positive women, this has never been proven to be an increased risk for pelvic infection. And if they had an IUD in place, you would leave it. And so, I mean, I think in general, if somebody was a liver transplant patient, you would say the risk of unintended pregnancy in the beginning especially is greater than the risk of pregnancy, and that you would want to do something that's effective to prevent pregnancy for at least 1 to 2 years. And it might even include, in this particular paper, using 2 forms of contraceptive, one hormonal like a progestin only method or a copper IUD plus a barrier, just to be as cautious as possible till it would be safe to get pregnant. Once they do get pregnant, they would need to be followed by a maternal fetal medicine specialist. And so just to go through finally in my last few slides, a case of a 32-year-old woman who underwent a liver transplant caused by autoimmune hepatitis. She is post-transplant now. In the past, she had been on birth control pills that were a combination pill and did well. She wondered about starting these. She knows she doesn't want to get pregnant for at least 2 years, and you also don't want her to get pregnant for at least 2 years. So she would like to think about what are options. So many of her friends have IUDs, but then somebody mentioned it might not be safe if she's on immunosuppressive drugs. She isn't sexually active yet because she hasn't been feeling good, but she's starting to recover and be interested again. And so she wants to know, what could she do? She isn't pregnant right now. And so in this particular patient, you know, in general, and you can say if this isn't true, but I think pregnancy avoidance would be recommended for at least 1 to 2 years. There really is no evidence that a IUD is more risky for developing infection if they don't have an active infection and they want that method. It's very protective, highly effective. And the other option to consider would be a progestin only pill or implant, because if her liver function is returning to normal and she's recovering, you could consider safely doing that. She would not be a candidate at this point for combination oral contraceptives. And so again, I would just like to point back to this, you know, picture here that goes through what the different options would be. And actually, if they're uncomplicated and doing well, they could consider a combination pill, although I haven't typically done this. I usually choose either a progestin only or some type of IUD and try to avoid estrogen if possible. And so the bottom line, the take-home messages are that the US medical eligibility criteria can help providers decrease barriers to choosing safe and effective medical contraceptive decisions, even based on a complex medical history. Most women can safely use most contraceptive methods, but you should consider their impact on known liver disease, or if new possible liver-related symptoms arise, you know, address those appropriately. And, you know, that men, women, and couples should be informed of the full range of methods to decide what will be best and safest for them. Okay, thank you.
Great. Thank you, Dr. Rhoton-Vlasak. You know, I neglected to give you your full introduction. She's an associate professor at the University of Florida in the Department of Obstetrics and Gynecology. She's in the Division of Reproductive Endocrinology and Infertility. Her areas of interest include treating conditions leading to infertility, as well as other reproductive endocrinology disorders, including amenorrhea, endometriosis, hirsutism. And related to this, but somewhat of a tangent, she has a special interest in fertility preservation in cancer patients, which is a program that she's continuing to develop at the University of Florida. So thank you very much.
Thank you.
I think, yeah, feel free to put in any questions in the Q&A box. I don't see anything currently.
I have a question. Can I ask a question
Who you ask?
to the panel?
Oh,
So, I mean, is this pretty much sound like in clinical practice how things are handled when you see complex patients or, you know, of a reproductive age? Because sometimes what we think is occurring isn't exactly how, you know, it can sometimes be slightly different than what we see it from our standpoint in gynecology.
yeah, Dr. Zori, you know, I'll give you an intro and then I'll let you answer that question.
Sure.
So that we can kind of segue into your section, although it's a little bit of a tangent in terms of that.
Sure.
Dr. Andreas Zori is an assistant professor in the University of Florida Department of Medicine in hepatology. He's an expert hepatologist and a critical member of our transplant hepatology team. And I hope that he has an answer to give to that question.
I'll take a stab at it. I mean, what's kind of in the front of my mind in terms of your talk was the transplant stuff. And I think, you know, I agree with your recommendation, you know, trying to help people not have pregnancy in the first year, especially after transplant. And then we also counsel them that it's important to be aware that mycophenolate is associated with brief defects, and during that time, we recommend, you know, if they're of childbearing age, that they be on 2 contraceptives. But once
But one of the contraceptives could be their partners.
yeah, exactly. So once they get out of that window, then I agree. You know, I think it's then I pretty much agree with your recommendation. We definitely have people on oral contraceptives. We just, especially when they first get on them, we're just very conscious of monitoring their immunosuppression levels, keeping a close eye on that.
Good. So, I mean, look, it's sometimes you never know, are you exactly overlapping with reality in your world? And it sounds like it, you know, what we are saying, what we do or what we think is matches up. So that's good.
Yeah, and in general, you know, the first year, we do have a higher level of immunosuppression in these transplant patients, and over that time, the immunosuppression level goes down. So, you know, I think beyond that first year, we're at a safer, more stable spot. So it's a little easier to manage then, as opposed to the early post transplant period. There was a question in the Q&A about what is your contraception recommendation in the setting of pregnancy-related liver complications, such as help with elevated blood pressure?
So that's a good question. And even some of the maternal fetal medicines may weigh in on this, Dr. Gregg and Genc, but I would say that if the patient is recovered, you know, back to normal, no longer hypertensive, or has no residual liver disease, then at that point, any type of option would be available. If they have residual chronic hypertension or, you know, anything else like that, then you might have to look at your charts and consider what's safe in those patients. So I would say in general, if they recover and it's been enough time since delivery and there's no contraindication because they're also breastfeeding, then, you know, that isn't a distinct contraindication over time to any option. But, you know, most patients, like if they have a history like that, usually what I do is I will actually start them on what we decide after counseling. And then I see them back in a month and do a blood pressure check, see how they're doing, make sure nothing's new come up, and then monitor them, you know, more regular, you know, more at more extended intervals after that. Would you agree, Dr. Gregg and Dr. Genc, about that or not?
I would. I mean, I think preeclampsia or HELLP syndrome is a multi-organ disease, and it affects obviously the liver. But if the liver is recovers from that, and the the inciting organ is obviously the placenta, and after the patient is delivered, and after a considerable amount of time, perhaps I don't see any. I don't think, as you said, we have any evidence that we shouldn't be using that. I have and I know we're going a little bit over the time, but and I'm really not expecting to answer this question, but perhaps in the future we should add this topic. I guess the assisted reproductive technologies is also a challenge in patients with liver diseases, for the same reasons perhaps we talked about contraception.
Yeah, so women with liver disease that's well controlled, I would say, are candidates for getting pregnant through assisted reproduction. I would say the biggest risk is if they have decompensated liver disease and they have a bleeding disorder. Obviously, that's a problem if they would be going through IVF for bleeding with egg retrieval. So I think it depends on their degree of liver disease, which treatment you're thinking of, and what medicines they have to be on for treatment of that liver disease. So all those things are taken into consideration when we decide what treatment, what's safe, what's not in that scenario. And I do have, I'm trying to think, I probably have, I don't currently have any patients or any of my direct patients ever that had a transplant, although Dr. Gregg did, but I've seen people with like autoimmune, with fatty liver a lot from PCOS, mostly non-liver enzyme elevated different hepatitises who are like sort of in remission. And most of
What
those,
about hepatocellular adenoma, for example?
I mean, I have not seen a patient with that who was seeking treatment, but I think what you'd have to tell them is that the estrogen levels go up high in that treatment, and there is a theoretical risk that you could affect that adenoma and make it grow more, become symptomatic. I think that's something you'd have to acknowledge and monitor them for. That's an excellent question.
Thank you.
Great. Well, let's move on to Dr. Zori, who will be speaking to us about autoimmune liver diseases. Maybe we should have had him give his talk first, or maybe he would have stolen the wind out of your sails. But yes, autoimmune liver diseases and pregnancy.
All right, let me just pull up my slides. All right. So as Dr. Zori mentioned, my name is Andreas Zori. I'm an assistant professor at the University of Florida in the Division of Gastroenterology, Hepatology, and Nutrition. So I'm a liver doctor, and I see patients with liver disease and after liver transplant as well. The objectives for this talk are to discuss the risks to the mother and fetus associated with autoimmune liver diseases, primarily taking a focus for patients, outline recommendations, interventions, and monitoring for pregnant patients with autoimmune liver diseases, discuss the specific differences between autoimmune liver diseases during pregnancy, and explore the outcomes and common risks associated with the cirrhosis. So again, I'm a liver doctor, so I'll just kind of touch on these, and if I get any tough questions, I may have to phone a friend. Provide a framework for navigating pregnancy, if you have liver disease. So again, I'm going to get kind of a little bit basic and then get a little bit more into the weeds. So start by just a quick overview to make sure everyone's on the same page. Primary sclerosing cholangitis is inflammation and scarring of the small and large bile ducts, which causes narrowing and blockage of those bile ducts, which can result in infection called cholangitis, abscesses, and stones as well due to blocked bile ducts. This condition also increases the risk of liver and bile duct cancers and can be progressive to cirrhosis, often is progressive to cirrhosis. So as you can see in this diagram, you get this kind of beaded appearance to the bile ducts, which normally are kind of smooth and tapering, and this can cause a variety of issues. So how do you approach a patient who is considering pregnancy? I think one of the big things that needs to be discussed is the need for invasive procedures. So these patients, because of these folks can have narrowings of the bile ducts, which can require stenting or dilation with an ERCP. And frequently these patients may also have ulcerative colitis, in which case colonoscopy may be warranted. So therefore, I think discussing with your physicians to see if any of these procedures anticipated in the upcoming months or year, because it's safer to do it prior to conception. I think the other thing that's important is to ensuring that you're up to date on appropriate cancer. So specifically for patients with PSC, they should be screened for cholangiocarcinoma or bile duct cancers about every year or two, as well as if you have ulcerative colitis, again with a colonoscopy. In patients with cirrhosis, they also require cross-sectional imaging or an ultrasound to screen for this, but we'll go into the recommendations specifically for cirrhosis a little bit later in the talk. In terms of how you manage or having PSC during pregnancy, it's more common to have itching during pregnancy. And this can be treated. There's a number of options with antihistamines, cholestyramine, or ursodeoxycholic, among others. In general, there aren't any medication changes that need to be made because there aren't good medications for primary sclerosing cholangitis. But we do recommend that you avoid Cipro if possible, ciprofloxacin, if you develop cholangitis or infection in the bile ducts. In terms of the imaging, if that's needed during the pregnancy, ultrasound is generally considered safe. MRI or MRCP, again to evaluate the bile ducts, is generally considered safe, but in general recommended to, if possible, do in the second or third trimester. CT scans, anything that requires radiation, in general, we try to avoid it unless you absolutely have to due to the risk of radiation to the fetus. Procedures, especially ERCP, we try to avoid these unless absolutely necessary. Again, also prefer the second trimester because it reduces risk to the mother and the fetus. So in terms of outcomes, we have pretty limited information on this topic. So kind of the best information that we have is that there is an increased risk of preterm labor. It may be up to 3 times normal, with one series reporting it to be about 16% versus controls or kind of the standard patient being more in the range of about 5%. The need for C-section is also probably increased somewhere about 2 times the normal rate. And it's more common if they have abnormal liver numbers, especially ALT or bile acid elevation. There's no known association with stillbirth, neonatal death, congenital abnormalities, PSC progression, or maternal mortality. And I think overall pregnancy can be completed safely under close supervision. So I think just the important thing is making sure you have a plan with your gastroenterologist and your OB/GYN. The presence of portal hypertension, however, is associated with higher risk. And we'll discuss that again later on when we talk about cirrhosis. Primary biliary cholangitis is an autoimmune inflammation of the small bile ducts. Slightly different than PSC in that the inflammation is generally microscopic rather than actually where you can see the narrowing. This, you have inflammation around it, and this inflammation eventually can cause cirrhosis. It's associated with a number of autoimmune conditions, including Sjogren's syndrome, which is dry eyes or dry mouth, Hashimoto's thyroiditis or hypothyroidism, osteoporosis and osteopenia, thinning of the bones, as well as vitamin deficiencies, especially vitamin A, D, E, and K. So in terms of what do you do before or in early pregnancies, I think the important things are making sure you have adequate screening for associated conditions, because especially things like hypothyroidism and vitamin deficiencies can have significance for both the mother and the developing fetus. It's also important to discuss screening for esophageal varices, as some of these patients, some folks can develop varices even in the absence of cirrhosis. Treatment during pregnancy. The most common medication used for the treatment of PBC is ursodiol. In general, this is considered safe. It should be continued, shouldn't be stopped. Obeticholic acid is a newer medication used for the treatment of PBC. And because it's relatively new, there's very limited safety data. So this, if you're on this medication, it should be discussed with your doctor. And some folks, some physicians recommend not using this medication if it can be avoided. But again, that decision should be made with your physician who knows you specifically. Itching, this is a common problem for patients with primary biliary cholangitis, but this tends to be a worsening problem during pregnancy, and for those who don't have it, it's not uncommon to develop it. Again, it has a number of treatment options, including antihistamines, rifampin, cholestyramine, and ursodiol. Outcomes, again, there's also very limited information on this topic, primarily because it's uncommon disease overall and uncommon pregnant in females of childbearing age. Maternal outcomes. Stable or improved disease during pregnancy is seen in about 70% of patients. However, postpartum, 60 to 70% will have sort of flares or elevations in their numbers. These numbers tend to come down and tend to not be of significant, at least as far as we know, be of clinical significance. It's very rare, or it's rare that it leads to progression of the liver disease or cirrhosis. Fetal outcomes, this condition is associated with a higher rate of miscarriage. However, 91% of people with PBC, women with PBC, are able to have successful live births. So although they may experience a higher rate of miscarriage, in general, most can have babies. There's no association with preterm labor, stillbirth, or other adverse outcomes. Autoimmune hepatitis, this is an area where there's more data because patients tend to be younger and female. This is a condition where the immune system of the patient kind of attacks or causes inflammation in the liver. It can be progressive to cirrhosis and presents with cirrhosis commonly. It's treated with immunosuppressive medications, which reduces the risk of progression and also reduces the risk of complications, both in general public and also in pregnant patients. Treatment in general, active disease significantly increases the maternal and fetal risks. So adequate disease control and treatment is important, is paramount. Stable doses of immunosuppression and labs, stable labs for more than a year is in general recommended. So in patients that I have, I try to tell them they should be on some sort of contraception and should not get pregnant unless we know that their liver disease is very stable. And we'll get into a little bit of why that is in just a minute. Medications, which are commonly used for autoimmune hepatitis, azathioprine in pregnancy is associated with low birth weight. And birth, and birth considered low of palate, but this has kind of been in question. Tacrolitation, however, is contraindicated in pregnancy. So if you're considering weight, you should try to get off of that as soon as possible. But in general, for those three medications, azathioprine, prednisone, / budesonide, and tacrolimus, generally the benefit you shouldn't just stop these with 7%. It's higher. The risk of decompensation of the liver disease is higher if a patient has cirrhosis, about 21%. And really, you should be monitored very closely both during the pregnancy and then also for 6 months postpartum. The fetal outcomes, there's no specific risk of birth defects. However, there's a high risk of preterm birth, about 20%, small for gestational age, and a rate of fetal loss up to 30%. So cirrhosis is a condition which is severe scarring of the liver. The scarring results from any type of chronic inflammation. And for folks with cirrhosis, we use a MELD score to estimate the severity of their liver disease, which is calculated using 4 lab values. Fertility in cirrhosis is in general reduced, but is possible. And cirrhosis as a condition is associated with confusion, which is called hepatic encephalopathy, fluid accumulation in the abdomen, which is called ascites, and bleeding in the GI tract, which is usually as a result of varices. Varices form as a result of the scarring of the liver, impedes the blood flow through the liver from the portal system. This is a vein that goes into the liver, drains the intestines, among other organs. If there is severe scarring of the liver, that flow is impeded, and that pressure that builds up is transmitted back into the veins along the stomach and along the esophagus. These veins can swell, and under high pressure, they can burst and bleed. And those bleeds can be significant and can be life-threatening. So this is kind of the most feared complication of cirrhosis, and especially during pregnancy. If people develop any of these 3 symptoms or elevated MELD score in general, we term that decompensated liver disease. So what about fetal outcomes in patients with cirrhosis? So we know they have higher rates of intrahepatic cholestasis of pregnancy. They more frequently require induction of labor. They have higher rates of preterm delivery, have higher rates of infection. They have large gestational age is more common, and neonatal respiratory distress is also more common. Fetal mortality is likely also increased. There's been some difference in terms of how much it has increased, but some places it's reported 0.7% as opposed to a baseline of 0.3%. Other places it's been reported about 5.2% as compared to sort of the controls or standard being about 2.1%. What about maternal outcomes in cirrhosis? In general, the risk of death or needing a liver transplant is low, 0.3%, and decompensation is 1.6%. However, older data has suggested that the risk of decompensation is quite a bit higher, all the way up to 15%. And again, that may be a function of a number of things, including how well we are able to manage cirrhosis these days. The most common mode of decompensation is variceal hemorrhage, with about 60% of people who have decompensation during pregnancy being hemorrhage. Again, speaking to why that is one of our primary concerns in managing pregnant patients with cirrhosis. The other 38% or so are a result of hepatorenal syndrome, which is worsening of the kidney function, hepatic encephalopathy, or development of ascites. However, I think an important note is that the rate of decompensation, the rate of negative outcomes is significantly higher in patients who have already decompensated disease as opposed to people who are compensated. So in terms of cirrhosis management, what we recommend is that variceal screening should be done within 1 year prior to conception. If it was done within 1 year prior to conception and there were no varices at that time, there's no change in management that's required. If at the time they had small varices, you should at least consider a non-selective beta blocker. The reason why we consider this is during pregnancy, there's a change in blood flow to these vessels and they tend to swell or grow during that time. So even if they're present and small, I think most people would probably err on the side of treating with a non-selective beta blocker because propranolol especially is considered safe during pregnancy. If you have medium or large varices, they should be treated either with a beta blocker or with banding of the varices until they're eradicated. If this endoscopic screening has not been done prior to pregnancy, it's recommended that it be done in the second trimester of pregnancy, because as I mentioned, that's kind of the safest time to undergo an endoscopic procedure. And then if that's the case, then if that is done, then the sort of same recommendations apply. And also in patients with cirrhosis, liver cancer screening either with an ultrasound or cross-sectional imaging. Liver cross-sectional imaging should be done every 6 months. So ideally prior to pregnancy and then at 6 months. So in terms of how do you approach cirrhosis if you're a patient, how should you approach your liver disease if you're a patient? I think kind of the first question that I think you should ask is, do I have cirrhosis? And if you do not have cirrhosis, then it depends a bit on which liver disease you have. Regardless of which it is, though, you need to make a plan with your liver provider and your GYN provider because each of them require some specific considerations. If you have PBC, you should be screened for associated autoimmune conditions and nutritional deficiencies. In some cases, also be screened for esophageal varices. If you have PSC, I think the more important thing is screening for cancers and planning any necessary procedures. If you have autoimmune hepatitis, I think the primary thing to do is discuss if your medications need to be modified and the risks associated with them to you. Also plan lab monitoring in terms of how frequent it's going to be, and also then post-delivery lab monitoring. If you do have cirrhosis, it requires a little bit different approach. And that also depends on whether you have compensated cirrhosis. If you have compensated cirrhosis, again, it's very important to make a plan with your liver and GYN provider to let them know that you are higher risk and that you're going through a pregnancy. So you can talk about what needs to be done beforehand, including esophageal variceal screening. Also cancer screening, as we mentioned, needs to be done every 6 months. And then disease-specific considerations, which are here down below. If you have decompensated cirrhosis clinically, or your MELD score is above 10, I think you need to also have a conversation with your GYN and liver provider about whether pregnancy is safe for you. I think there's there are other options in terms of starting a family. And I think there are significant risks, including death to patients with severe liver disease. So just kind of make a plan in terms of what to do. I think probably the best approach. And then if you choose to proceed with a pregnancy and are able to get pregnant, again, fertility rates are reduced, then the same kind of things apply. Screening for varices, cancer screening, and disease-specific considerations. And then I think the last question, which sometimes comes up, is are these diseases hereditary? The cause of all of these diseases is complex. Probably involves quite a bit of different genes and environmental factors, including the microbiome. But in general, I think we say that no, they're not hereditary. There may be a slightly increased risk of getting some of them, and there are, of course, always some exceptions, especially with a very rare form of autoimmune hepatitis. But in general, we say there's very minimal risk, if any, to the baby. So in summary, if possible, discuss pregnancy with your GI and liver provider before conception, because making a plan ahead of time, I think, always results in better outcomes. Close monitoring during pregnancy is recommended for patients with autoimmune liver diseases. Patients with autoimmune liver disease can have safe pregnancies and delivery, but there is an increased risk to the mother and baby associated with cirrhosis. But the risk of serious complications in general is low, with the exception of patients with decompensated liver disease. Those are my references.
Great, thank you very much. Let's see, yes, any questions? Please put them in the chat box.
Can I ask a question of Dr. First of all, great talk, Dr. Zori, and really a topic that in the MFM world we're not very familiar with. These liver diseases that are chronic, I think, as Dr. Rhoton also inferred, these patients are sometimes infertile or have reduced fecundity. And I just wonder, you know, are the recommendations, do you think, are they borne out in lots of data, or do they tend to be consensus recommendations around management? I just wonder if the hepatology societies have, you know, we all agree on generalities, like a team approach to care is always advised in these kind of situations. But I just wonder, in general, if we were going to encounter these in pregnancy, how much pushback are we going to get in the conversations? Because we do push back on each other, as we should, in managing patients where the medical complications are very, very uncommon. And I just wondered what your thoughts were. Do the guidelines and the management, for example, just using a non-selective beta blocker, we commonly use that in various types of vascular conditions where dissection is a concern and that kind of thing. So it seems to make sense, even in the case of varices. But I'm just wondering, are there trials where we know some of this to be founded in a good body of literature, or are we generally operating out of consensus?
Yeah, I mean, I think in terms of the kind of screening, cancer screening stuff, a lot of that is basically just taken from, in general, people with liver disease, specifically in terms of, which there is pretty good data from, especially for the cancer screening stuff. Although I will say for PSC, the recommendation for how often and with what people should be screened with for cholangiocarcinoma is very vague. Basically says like every year or two you should do something, but then they don't say with what. So, so that I think is on pretty good data in terms of specifically for patients with liver disease. Most of it is based on retrospective series, oftentimes from countries with socialized medicine, where they're able to, look at all of the patients with liver disease, with this specific type of liver disease, or 2 or 3 centers. But again, when they do that, I think especially with PBC and PSC, they're relatively rare in patients of childbearing age, especially PBC. So the data there is not very good. It's definitely not on the level of trial in terms of how to manage them. And that's kind of why I added those disclaimers. It's kind of what we got, unfortunately.
Yeah, I really appreciate that you guys are specialized in these conditions, because I think when they do happen in pregnancy, they can be devastating in so many ways. I mean, earlier deliveries than need to be, and of course, very bad maternal outcomes if we're not careful. So I really appreciate you guys.
Sure, no, we do too. We appreciate you guys. And so it looks like there's another question from Dr. Rhoton-Vlasak. It says, how often do people have disease progression during autoimmune liver disease? So PSC and PBC is very uncommon to have progression of their liver disease during pregnancy, but at least as far as we know, again, the data is not there's not that much data on this. Autoimmune hepatitis, there's a significant risk of decompensation during pregnancy. So those are the people that we really want to watch really closely and want to make sure that they're well controlled going into it. Because there's significant risk. I forget my numbers now off the top of my head, but I think it was about 30 or so % will have some kind of progression or flare, at least. I think frequently what happens during pregnancies, they'll have a sort of a flare where the numbers will go up, and we'll have to treat them more aggressively with immunosuppression. So higher doses of prednisone or something along those lines to try to get it back under control.
Thank you.
Yeah.
Wonderful. Dr. Zori, thank you so much. Unless we have any other questions, I want to move to our next panelist, Dr. Anthony Gregg, who's joining us from Prisma Health, the University of South Carolina, Greenville campus. Dr. Gregg is a longtime colleague and friend. He was actually the one who recruited me to University of Florida. He was the chief of maternal fetal medicine division. And then he went and joined a group at Baylor University Medical Center, where he was part of a group that did the first uterine transplantations. During his time at the University of Florida, he was our go-to person for patients with liver transplantation and who were pregnant. So he comes with a vast experience in not only patients with liver transplantation, but patients with other solid organ transplantations and pregnancy. So without further ado, I want to leave the podium to Dr. Gregg.
Dr. Genc, thank you very much for inviting me to speak. And, I'd like to really, I guess, restate what I was saying earlier, at least as far as I'm concerned. And I heard Dr. Rhoton say the same thing, that I don't consider myself an expert in liver transplantation in pregnancy, having taken care of several patients with a prior liver transplant, because I'm not sure that several patients makes anyone an expert. And these pregnancies aren't that common. And I would love to hear the experience of the attendees and even the other panelists as you know, how frequent this has occurred and what your experience has been with this. This title slide is important. It really depicts one of the mythical Greek myth stories of what's called liver regeneration. Pregnancy is sort of, if you will, regenerating mankind. And in this picture, it's showing Titius. Titius was the son of Zeus and Alara. And of course, Alara was a mistress that Zeus had. And he had this child not with Hera, his wife, but with Alara. And he hid Alara deep into the earth. And she bore Titius. And Titius was, of course, Titius was breastfed by Gaia, who is the god of the earth. And Titius grew quite huge. Of course, as a god himself, he was immortal. And his fault was, and what brought him to this place was that he attempted really a sexual assault on Leto. And of course, Leto was the mother of Apollo and Artemis. She called on her sons to kill Titius with their arrows. And of course, him being a god could not be killed, but Zeus condemned Titius to Hades, where a vulture ate some portion of his liver at least every day, and it regenerated over and over again. Liver transplantation is, to me, quite amazing, and I know that you're doing, I don't know what the term is, partial resections of living donors, and it's a phenomenal procedure. I do have no financial disclosures. I am at Prisma Health now, no longer at Baylor University Medical Center in Dallas, although I continue to have a relationship with the uterus transplant team. And I want to say that the uterus transplant program was actually run under the direction of the director of the liver transplant program. And I'm reasonably close with that team today, and we continue to publish on our results. And I'll draw on a few of the experiences and observations that we've had in uterus transplant and make some observations for you here with the liver transplant population. Overview in general, I do think it's really important to understand estrogen. After all, it's pregnancy. To get pregnant, as Dr. Rhoton also alluded to, we need to have an intact hypothalamic pituitary axis if we're not otherwise going to use assisted reproductive technologies. I want to talk a little bit about the preconception consultation. In fact, I'll talk a lot about that, emphasizing what are the risks of pregnancy, if you will. And then I want to say some things about medications. I'll close with what would be the caveats of antepartum care, if you will, and then be happy to answer questions after that. So let's start with this business of estrogen synthesis. And I just was thinking about this. You know, here's the patient with a liver transplant. That liver has to be working reasonably well for this pregnancy to go uncomplicated. The sick patient, we all know, has these symptoms that are associated with liver disease, and you have heard of these already as people have talked about cholestasis of pregnancy, for example, and maybe even PUPS and some of these things, where the palms are itching because of bile acids and the feet are itching. When estrogen is around in abundance, where did that estrogen really come from? And the long and short of it is the estrogen comes from several sources in the body, but during a pregnancy, during a naturally conceived pregnancy, there's going to be a lot of estrogen around, and it's coming from really a combination of the theca and granulosa cells. And you can see where these pathways in the center interact. You can, of course, get estrogen production from the adrenal steroid biosynthesis pathway. Again, many of these enzymes are exactly the same, just operating in different tissues. But what I really was trying to find out and determine was where is estrogen metabolized? And of course, it's metabolized in the liver. And how is it metabolized? And I mean, can you imagine a pregnancy if the liver were failing? The kind of symptoms the patient might have in terms of the itching and even the hypervascularity and the rubra in complexion that the patient might also have. So I wanted you to recognize that estrogen is in fact metabolized by cytochrome P450s in the liver. There are several pathways where estrone is converted to metabolites that are ultimately excreted in the urine. Now, this might seem to have been really off-center, but as I mentioned, an impaired estrogen metabolism is an impaired pituitary ovarian axis, and it is essentially impaired fertility. I'm going to come back to estrogen in a minute, and I'm going to come back to the intact pituitary ovarian axis in a minute. But keep these thoughts in mind. And I want to then shift gears to a patient that I saw today. This patient, I've camouflaged some of the demographics, so she couldn't possibly know that I'm speaking of her. But autoimmune hepatitis was something that she had from a fairly early age in childhood. And in her mid-20s, she underwent a liver transplant. Her gynecologic history, I think, is important here in that she had an ascus pap, colposcopy, biopsies in her early 20s, late teenage years. And I wanted to make the point that many of the patients that finally undergo a liver transplant have also been on medications that lead to being immunocompromised. And we know from our HIV population that these patients are much more predisposed to viral infections, and they're actually predisposed more to cervical cancer if they have the proper viruses exposed to them. I say that in part because these are exactly the patients that come to multiple biopsies, sometimes leaps and conization of the cervix, that ultimately leads to a risk of an incompetent cervix. So taking the history of these patients and in particular their gynecologic history, I think is critically important. It turns out it's critically important as well in the uterus transplant population, in that it was very important that we understood the donors. These were living unrelated donors primarily in the Baylor program, but really trying to understand what condition the cervix was in as we enter a pregnancy. The question also comes, of course, are these patients prone to risky behavior, particularly because for many, many years through childhood and teenage years, they're dealing with chronic illness. The patient underwent a deceased donor liver transplant, and the transplant occurred less than 2 years ago. Again, we've heard a couple of comments related to the 2-year mark. Liver transplant and then a subsequent conception are thought best to be delayed for a period of about 2 years. Now, uterus transplant was quite different, and uterus transplant is a temporary transplant. I just want to make that point. And the sooner we can reach our end goal, which is maximum 2 children or 2 pregnancies that reach a age where children will do well. So the sooner we can start embryo transfer, the better. The least amount of time, then these patients have to be on serious immunosuppressive drugs. It's interesting to me, when we first started the uterus transplant program, the wait time was 6 months to a year before an embryo transfer would take place. In the liver transplant population, the recommendation is to wait 2 years. And again, I question whether or not that can be reduced. And I don't have data to support it, but it goes back to what's really an evidence-based recommendation and what might be a recommendation that's really consensus-based. And of course, one of the key features here may well be that the liver transplant, of course, is a life-saving organ. Uterus transplant is a life-enhancing organ, very different types of transplantation. And to screw up and not really have a stable transplant in the liver transplant population has very serious, of course, ramifications. Not that it isn't serious with uterus transplant, but again, it's not a life-saving transplantation. Importantly, this patient recently started regular menses. Her menses were always irregular previously. And what does that mean? I want to maybe posit that this means the liver is working well, that hypothalamic pituitary ovarian axis is now functioning well, that she can say to me that she's having regular menses. This is the preconception consultation. And that they were always irregular previously maybe speaks to the fact that she's been treated for a very serious chronic liver disease with multiple, of course, medications. You know, in the uterus transplant population, we measure success through multiple stages. There's, of course, the technical success of the transplantation itself, but menses, establishing menses, is step 2. That's before embryo transfer, the establishment of a pregnancy, delivery, and then, of course, subsequent hysterectomy. So we have multiple stages to go through in uterus transplant. Here, they're monitoring for rejection. And it may just be that there's a confidence level achieved when you're 2 years out and stable with regards to your uterus transplant, or excuse me, your liver transplant. But I'll come back to the issue of mycophenolate in just a minute, because it is one of the big guns that's used to prevent rejections. So menses as a measure of successful transplant, I put that in question mark. The interval between transplantations and resumption of menstruation did not correlate with age, duration of amenorrhea, or the underlying diagnosis. And you can see from this graph on the right that really by 12 months, nearly all patients have resumed menses. The resumption of regular menstruation in some women over the age of 50 years was even an unexpected finding in this particular study. So when the consultation comes in, the basic question the patient asks is, can I have a healthy pregnancy? And to me, that's a very loaded question. Healthy for who? Healthy for her, and what are those risks? Are they different than those in the baby? And have a healthy baby, and what is she thinking of in terms of a healthy pregnancy? Is she thinking she's going to get to 40 weeks, which is her due date? Or is she willing to accept some risk of having a preterm birth? So I generally like to start the consultation with trying to get more information, more historical information. I think it's really important, as you'll see in a second, to understand what the underlying etiology is. There are patients who have an underlying etiology that's going to maybe predispose them for more episodes of rejection. And rejection during the pregnancy may not bode well for the pregnancy outcome and even the patient. It's important to review expectations and compare the risks of what's known about the transplanted patient to what's known about patients with the same conditions or those patients that get pregnant who have that underlying liver disease, as Dr. Zori talked about, leading up to the time of transplantation. What are those pregnancies like relative to the post-transplant patient? We want to discuss medications, in particular mycophenolate, and the need for a washout period. I will tell you that in the uterus transplant population, the washout period, we reduced the time of washout from stopping mycophenolate to 3 months. Early in the uterus transplant program, we kept mycophenolate on board for 6 to 12 months. And by reducing the mycophenolate exposure time, we were then able to move earlier to the embryo transfers needed to achieve successful pregnancies. And so, again, it's important to discuss with those patients who are on mycophenolate that there is a recommended washout period. And I would suggest that 6 months might be the right time frame in this patient population. Low dose aspirin, 81 milligrams a day. I would discuss the rationale with the patient for using this in pregnancy, although the U.S. Preventative Services Task Force and ACOG recommend starting low dose aspirin to prevent preeclampsia, generally after 10 to 12 weeks. I see in my own experience, have had no trouble recommending low dose aspirin even earlier. And I found that many transplant patients are already on low dose aspirin. We don't ask them to discontinue that. One of the reasons that ACOG and the U.S. Preventative Services Task Force recommends delaying low dose aspirin for the prevention of preeclampsia is that in some of the studies using reasonably much higher doses of low dose aspirin, beyond 160 or 150 milligrams a day, closer to what we see in an adult aspirin or a couple of adult aspirin a day, there has been a proposed association with congenital heart defects. Again, that's not this patient population with 81 milligrams a day. The other thing I tell people is caution about the genetic testing being performed. We're doing a lot of cell-free DNA testing today, and there are potential concerns that underlie that testing. I'll try to come back to those at the very end of the talk. So the real question is it more likely than not I'll have a healthy pregnancy? And again, that requires some understanding of what the risks and the benefits are in terms of carrying a pregnancy and whether the patient wants to incur the risks. So again, talk to the patient, review medical records when these are available, talk to the patient's care providers. I mean, I pick up the phone regularly and talk to the internal medicine teams that are involved with the various types of medical complications for which I'm seeing patients all the time. So what are the specific underlying etiologies? Just keep in mind that you're not likely to run into the patient with cirrhosis due to alcoholism. These are not usually good transplant candidates, largely because of their social barriers. The patients with underlying liver cancer, those patients tend not to come to our clinics because, again, liver transplant doesn't serve this population as well as it does some of those others noted in a darker font above. The etiology can impact graft survival and the kinds of immunosuppressive therapy that are required. And again, if mycophenolate is really required as a long-term management option, this isn't the kind of patient for which a pregnancy is likely to be recommended. So again, understanding the etiology of their liver disease is important. So I'm going to break up the complications in several different bins. I'll start with maternal complications, and I'll use the same general registries that are shown here. There are two registries that at least are published by this author here in 2012. This author also looks at population studies and case series, 595 pregnancies, 690 deliveries. You can see that the biggest concern as it relates to maternal outcomes is the problem of rejection. And it's really important, team-based care, making sure that drug levels, when it's appropriate to monitor drug levels, are really being monitored well. We can anticipate requiring a increase in dosage of medications, particularly tacrolimus if the patient is on tacrolimus, because pregnancy, as we know, dilutes because of the volume of distribution. There's an increased blood volume in pregnant patients. Their cardiac output and the amount of blood volume going to the kidneys, going to the liver, means increased metabolism of these drugs. And so following these medications carefully is really part and parcel to trying to avoid rejection. And even then, it can't always be accomplished. So that's a critical piece to the management here. A rejection, of course, is a devastating complication. On the other hand, rejection can be managed. Patients generally don't come to us taking high doses of steroids, but at the earliest onset of rejection, or what's thought to be rejection, patients might be started on high doses of prednisone to manage that. And we did have rejection in one of our uterus transplant patients, rejection before she went to conception, before we moved the embryo. Before we did the embryo transfer, leading up to her embryo transfer, she was experiencing rejection, and we managed that with high-dose steroids. She had no rejection episodes then, and neither did any of the patients that we managed throughout pregnancy. They had no rejection episodes with the uterus transplant population during the pregnancy. So anyway, very important complication. Now, this is a patient that I did take care of at the University of Florida. And I think some on this call know this patient. It's with her permission that I show you her and her family. She came to us early in pregnancy with quintuplets. And the question was, are we really going to try to carry quintuplets? And she was, of course, adamant about doing so. Despite the potential risk. Now you can imagine the blood volume to the liver, the blood volume to the kidneys, the struggle it would be to manage the anti-rejection medications in her case. But as you'll see, she did quite well in her pregnancy. She did have a setback several years later. It's uncertain whether pregnancy contributed to that setback. But the setback required that she proceed through a second liver transplant. That liver didn't do well.
So Tony, what was the cause of her? Tell me again the cause of her transplant.
You know, I don't want to go into the detail of the cause, but I believe it was an underlying infectious etiology is what I recall. And I'm sorry, I'm truly blanking on the exact etiology.
It's okay, her family's beautiful.
Yeah, and they are. And I stay in touch with this family, of course, on a regular basis, and they continue to do extremely well. But she actually required a third liver transplant. And you see her here, this is a picture after the third liver transplant. So the obstetric complications that are most commonly talked about and are of greatest concern include two. This first pink box outlines the first of those, and that's pregnancy-induced hypertension or preeclampsia. And in this study, they separate the two out. I'm not sure how that would be separate, how these would be separated out using today's definition of preeclampsia, which have become increasingly complicated. But I think you can see that there's a reasonably high percentage in this database. Now, it's really important because in this next slide, which is out of, and I guess the reference isn't appearing on the bottom of this slide, but this comes out of the BJOG journal. And this is a reference out of, I believe, Sweden. And this looks at preeclampsia after a transplantation and preeclampsia before a transplantation. Now, there aren't a lot of before liver transplantation pregnancies, and I mentioned that to you earlier, so it's hard to understand what the rate of preeclampsia is because we don't have an immediately before transplant population, or we don't have a 5 or 10 year before transplant population that we can look at very effectively. But if you look at the kidney transplant group, there is a high rate of preeclampsia, 22%. We generally call the baseline, you'll hear different numbers, but 5 to 7, 3 to 5, and in an earlier many years ago, 20 years ago, NIH document, they even had it listed as up to 10% of prima-gravid patients. But you can see then that kidney transplant increases the risk. Liver transplant, it's high out of this paper, very similar to the numbers that were shown on the previous slide. And 5 years before kidney transplant, you can see that it's not down to the baseline in the population. It's still high. We know that renal disease predisposes to preeclampsia. Well, again, what about liver disease? We don't have a lot of good information. So the odds ratios for preeclampsia are shown here after renal transplantation, about 9.6, 5 years before transplantation, 12, and 5 or more years before renal transplantation, that number goes down, so 6.5. And you can see the farther you are before your transplant means you have a healthier organ, and the healthier the organ, the least likely you are to develop preeclampsia. But preeclampsia and hypertensive diseases do occur with increased frequency in the liver transplant population. And there's some thought that maybe it's medication induced. The other obstetric complication that's really important is preterm birth or preterm labor. Now, this is listed as preterm labor in this document. Preterm labor is different than preterm birth, but I'm going to assume that in this particular document, and I couldn't grab my hands on the entire document, but I'm going to assume that this information is, I couldn't get my hands on these registries specifically, but in this particular document, preterm labor is the same as preterm birth. That is, that there's about a 30 to 50% in the UK registry chance of that occurring. So I think it's reasonable to tell patients they have a high probability of preterm birth when there is a liver transplant. And again, this before and after issue is important. I want to show the information from this Kalin paper in BJOG to you. This was published in 2005. Before transplantation, lots of pregnancies, 965. Overall preterm birth rate, about 21%. You can see when it was just a liver transplant, again, small numbers of patients leading up to that liver transplant was about 12%. Now 12% is about baseline in the population. We say there's a 10 to 12% chance of having preterm birth. So that's not terrible in those patients who are healthy enough to have a pregnancy. Born after transplantation, and you can see the numbers are small, pregnancies after transplantation. This is out of this particular single center, but still it's close to 30%. Low birth weight, of course, when you're born preterm, less than 37 weeks gestation, you're going to have a smaller baby. And you can see small for size, meaning that there's intrauterine growth restriction, isn't such a big problem in the transplanted patient. So exactly what's going on to lead to this is not clear. What causes the preterm birth? Is it altered immune cells in the maternal fetal interface? Lots of potential research opportunity here. And I will tell you that, we had the opportunity to share many specimens with people all across the world in our uterus transplant program. And so hopefully we'll understand more about the utero-placental interface in the transplanted population. Delivery outcomes, you can see here, there are cesarean deliveries, there are assisted deliveries, which would mean forceps and vacuums, and then there are what are called normal deliveries in this particular paper. Normal would be assumingly vaginal delivery without the need for vacuum or forceps. The point that I want to make here is that cesarean section is not the preferred mode of delivery, and it's not the required mode of delivery. So cesarean section should be performed for obstetrical indications in this patient population. Now, the quintuplets we had were delivered, of course, by cesarean section, as we do with any higher order pregnancy. And the quintuplets were delivered between 30 and 32 weeks, if I'm not mistaken. And they were delivered for obstetrical indications. That was preterm labor with advancing dilation. The patients are really concerned about their medications. They're concerned about not just whether their baby is going to be born early, but will their baby suffer developmental abnormalities because of those medications. And in this particular paper, you can see the odds ratios listed on the bottom. There was no statistically increased risk. This is the Swedish group of babies born with birth defects after organ transplantation. This was all comers. The patient that seems to have the most unusual type of birth defect would be this patient that was on mycophenolate in early pregnancy. And she had, this baby had esophageal atresia, complex cardiac defect, and an abnormality of the iris. I would also point out, though, in this paper that genetic testing wasn't what it is today. How many of these people with a heart defect had 21q11.2 or DeGeorge syndrome, which is one of the most common causes of congenital heart disease? What was the chromosome microarray in any of these babies with birth defects? We don't have that information because those genetic technologies were not available at that time. So it'll be interesting to see. I suspect the perceived risk will decline even further when we can reveal that there are other heritable and spontaneous genetic changes that lead to some of these congenital malformations. So what about, though, overall the fetal outcomes? You can see the live birth percentages, that the intrauterine fetal demise is not very increased. Spontaneous miscarriage or abortion seems to be increased in this patient population. Therapeutic abortion, probably related to those that are not compliant with contraception, as Dr. Rhoton mentioned, and intrauterine growth restriction was a complication found in these registries, but not a complication found in the Swedish study. So more to come, I think, as we see more and more patients undergoing liver transplantation and having then a desired pregnancy. This is the latest picture I got from the family of the quintuplets. You'll see they're doing extremely well. They seem to get along well. There was one birth defect in one of the girls, and I can't remember which one, but she had a defect involving her hand. She had a hand anomaly, and I attributed this more to a deformation rather than a malformation. She has undergone successful surgery, it's my understanding, and is doing quite well with her hand anomaly. But you can see they're doing great. When I left Gainesville, I was saying earlier, we all went out for pizza, the parents and myself. The kids were a bit younger than they are shown here, and they were all kind of shuttled in a contained space at a pizza parlor. And we took some nice pictures afterwards. I'm interested in the evolution of these medications that are used for transplantation, and it's really fascinating to me to read about the success stories related to liver transplant at the University of Pittsburgh in the so-called early days when Starzl was there. The transplant surgeon at Baylor in Dallas was a protege and really a student of Starzl's. And the evolution of these medications, I think, are what, and I think there's no question, others would agree, you move from a 26% survival rate in the pre-1980 timeframe to success rates that you will see in a minute are much higher with medications, cyclosporin, and then later tacrolimus. I was surprised that tacrolimus was developed in the late 1980s. There are head-to-head comparisons of tacrolimus. There are head-to-head comparisons of what was conventional therapy in 1981 and cyclosporin cyclosporin shown in the graph on the right. And you can see that basically the patient survival is highest with cyclosporin use. What happened when tacrolimus came on board was things got even better. These are complicated, complex medications in terms of their intracellular mechanisms. I show you this as related to this calcineurin inhibitor tacrolimus, and I show you in 1999 these mTOR inhibitors also work through very complex pathways intracellularly. It shouldn't be a surprise that we are rightfully concerned and that other organs other than the immune system might be impacted by these medications. And we'll look at some of that in just a second. As far as I'm aware, the evolution of these drugs hasn't gone much beyond the mTOR inhibitors most recently. And I think mostly because these medications are doing so incredibly well in facilitating transplantation. What are the agents that are commonly used, and any of those on the panel can make further comments in regards to these. I don't want anybody to think that the MFM team is the primary manager of these medications, but we should be aware of what these medications do and what complications might be associated with them, and we'll look at that in a second. But our contribution can be that we expect these medications to require some dose adjustment across the pregnancy. These patients are certainly seeing their hepatologist throughout the pregnancy, and adjustments are made and drugs are monitored. Now, is there drug monitoring for all of these medications? No, but certainly we do monitor tacrolimus levels, and I can let members on this panel speak to what you're looking for in these, but we stay in close contact with them. Really interesting to me, again, tacrolimus compared to cyclosporin for immunosuppression in liver transplant. I'm sure the panel members are very well aware of this, and this is why tacrolimus is preferred over cyclosporin, but not without some trade-offs. And again, both of these being calcineurin inhibitors. The primary outcome in this study, proportion of patients surviving, you can see it's about the same, but compare that to the 20 to 30% survival before 1980. And proportion of grafts surviving, again, about the same. The secondary outcome is rejection proportion with acute rejection. And you can see that there's fewer acute rejections with tacrolimus. Likewise, the proportion requiring a different medication, fewer with tacrolimus compared to cyclosporin. And again, happy to have the panel members chime in here in just a bit. In the non-pregnant population, we see the complications of nephrotoxicity, neurotoxicity, infection, rash, weight loss or gastrointestinal toxicity, death, lack of efficacy. All of these are complications in the non-pregnant patients, and generally speaking, it looks like tacrolimus has a little bit higher toxicity profile than cyclosporin does, especially as relates to nephrotoxicity. And in pregnancy, we're always concerned about nephrotoxicity. I mentioned the increased blood volume required and the work required by the kidney. When we see nephrotoxicity, we see rising creatinines, and we do get concerned. In the uterus transplant population, we delivered one patient early because she was experiencing nephrotoxicity from the tacrolimus. And then what are the toxicities associated? Calcineurin inhibitors, maternal diabetes, hypertension, preeclampsia, renal dysfunction, fetal or perinatal hyperkalemia. And it's important to let the neonatologist know what we anticipate might be problems due to these immunosuppressive agents. The azathioprine, on the other hand, fetal anemia, fetal thrombocytopenia, leukopenia, decreased fetal immunoglobulin levels, fetal neonatal infection and sepsis. And again, this association with preterm delivery and low birth weight we've already talked about. Corticosteroids, we are comfortable giving these, but we know that we can have an established gestational diabetes, fetal adrenal and therefore neonatal adrenal insufficiency can occur. Fetal cleft lip and palate has been already mentioned, I think, by Dr. Zori earlier. And mycophenolate, first trimester loss, therefore we're not using these medications if we can avoid it. Fetal malformations, you saw that in one of the earlier studies out of Sweden when a fetus was exposed to mycophenolate, and ear abnormalities are particularly common in those babies who are exposed. So this just shows the cyclosporin versus tacrolimus for liver transplant patients. And this is telling us that the tacrolimus is stratified by the formulation. You can see that there's a slight favor towards cyclosporin when it comes to diabetes in pregnancy. So tacrolimus might be slightly preferred, but it is also associated with diabetes or glucose intolerance in pregnancy. Antepartum care considerations. I'm going to close with these and just give you what my 2 cents are as relates to antepartum care considerations. First, it's team-based care. So much of the complex maternal fetal medicine today is involving hepatology, maternal fetal medicine, anesthesia, and neonatology. Set expectations early. Is near-term delivery preferred? I would even argue that even if the patient was doing beautifully, would it be beneficial to get off the pregnancy at 36 weeks, obviating any later potential complications such as preeclampsia that could rear its ugly head? And so I put question marks next to, I don't have any data, but my own preference would be to call it a day at 36 weeks. And I'd be happy even if somebody wanted to contemplate if there were some problems arising 34 to 36 weeks. Of course, we give betamethasone in the near-term period when we're contemplating a pregnancy. This should be pretty routine to do so. Well, should we modify glucose screening from what is usual? Should we do this at entry? into prenatal care, 22 and 32 weeks, like we might do for a high-risk patient that does not have a liver transplant? I would argue yes, at least a hemoglobin A1C at all of these time frames, and probably a 22 and 32 week glucola. But again, these aren't consensus recommendations by professional organizations. Early blood pressure treatment, I would argue that earlier than recommended by ACOG. You know, ACOG now recommends waiting until 160/110 before initiating blood pressure treatment in the uncomplicated, non-transplanted patient. I would say that we should be a little bit more aggressive here because of the at-risk organ and the fact that we don't want to suffer an early pregnancy loss by waiting until you have severe hypertension that can't be controlled. Monitor the creatinine, certainly on entry into care and at each trimester. These patients many times are on tacrolimus. They're very often migrated off of mycophenolate if they were on it in the preconception counseling visit, so that if they're on a calcineurin inhibitor, very important to monitor the creatinine. Neonatology consultation is important, again, because these babies are prone to having some immunocompromise. They are predisposed to having some hematologic changes and even some renal function abnormalities. So every single one of our uterus transplant babies actually went to the neonatal intensive care unit for a short period minimally of observation. Timing and route of delivery, again, I can emphasize that vaginal delivery is not contraindicated, and we were even contemplating vaginal delivery for some of our uterus transplant patients. However, we were a little concerned in the short period of time that the vaginal cuff scar might not maintain its integrity through a vaginal delivery. Should you do cervical length on all of these patients? You know, I would argue that every person with a solid organ transplant, because these pregnancies are so difficult sometimes to achieve and so at risk just because of those graphs and numbers that I showed you, we should be doing cervical length on all. However, again, there's a question mark there because I don't have data to tell you that will impact outcomes, but I think it's reasonable to do. Routine imaging, I think that's right. I don't think we need to step up the imaging. Of course, on the research protocol we had for uterus transplant patients, we saw them every 2 weeks in our ultrasound unit from very early on in the pregnancy. Is it overkill to do so today? I believe it is. A 12 to 14 week scan, an anatomic screen, and a growth ultrasound. These are targeted, all of these, looking at the baby. Should a fetal echo be performed? I'll leave it to the MFM team to decide on that. Our anatomic screens today are so good, we wouldn't probably routinely do that today. You might make the argument, though, that you should, and I wouldn't fight that argument. Again, cervical lengths on top of some of these other scans that are being done. So the anatomy with the cervical length at least once at a minimum. I might do it at 28 weeks as well. Antenatal testing starting at 32 weeks. That's just a question mark. Again, anticipate the preterm birth. You already saw that, at least in the larger compilation tables that I showed you, there was some suggestion that IUGR is increased in this patient population. Now, I mentioned non-invasive prenatal screening or the use of cell-free DNA to screen patients. Data from the uterus transplant trial showed that it predicted aneuploidy. We did this in 5 patients using 2 different labs. Fetal fraction was different between the labs. That's not a surprise. The way that fetal fraction is measured is proprietary across these labs. But they did pick the gender correctly. They did rule out aneuploidy correctly. And so the same, though, can't be said in the liver transplant population. For example, if it's a male donor and a female, there's high likelihood that there could be either discordant sex calls, a female fetus, and the cell-free DNA calls it a male because of the DNA being shed from hepatocytes that might be undergoing apoptosis during the pregnancy. So I would be a little bit concerned, maybe do it, but put the caveat in there for the patient, and that maybe you want to also do other types of screening. Of course, amniocentesis and chorionic villus sampling are not contraindicated. I generally stop low-dose aspirin beforehand, and I generally stop Lovenox. Some of these patients come to us on Lovenox before any sort of procedure. So in my experience with the uterus transplant population, we've done one amniocentesis, not for aneuploidy, but for viral infection screening. And the other patients just quite frankly didn't want to have an amniocentesis, an invasive procedure, despite the fact that there's a very low risk. So I'll summarize. I may have taken way too much time, and I apologize if having done so. But pregnancy following liver transplant should not be discouraged. I don't think there's a reason to discourage it. I think the maternal, obstetric, and fetal risks need to be explained carefully to patients, and they need to be willing to accept risk. Preconception counseling is of course recommended. Drug monitoring as needed and directed by the hepatology team and the transplant team are definitely encouraged. The awareness of drug side effects, such as the impact of calcineurin inhibitors on the liver. And I can't emphasize enough the team-based care approach to these patients. It's really gratifying when you have the outcome that I showed earlier with those quintuplets, but I do want to acknowledge the University of Florida liver transplant team. That really wasn't my work. It was their work over and over again, as you can see, to achieve that earlier picture. Can you imagine losing a liver and losing a mother when these children were 2 years old or 3 years old? That would have been quite a devastating outcome, really. And it's the transplant team that has been able to keep this family going. So my hat's off to them and the hepatologists who care for this family on a regular basis. I'll stop there and take questions. Again, I'm not an expert, so I would love for the whole panel to join in with their experiences. Thanks very much.
Great, thank you, Dr. Gregg. I think it's an important and unforeseen, at least for me, outcome of the uterus transplant program. How we're questioning some of our preconceived notions as to how we should deal with transplant patients in pregnancy. It's very sort of an interesting question. We have a couple of questions from Dr. Wen in the Q&A. I'll repeat them. So pregnancy complications after transplant. So I guess pregnancy complications after transplant, as opposed to other complications. Are they associated with the choice of immunosuppression medications?
Yeah, so it's a great question, and I don't have any data by which to answer. I think for sure we're asking patients not to be on mycophenolate, which is one. I think there's no disagreement among the panelists, and there's a needed washout period, whether it's 3 months is what we're using on the uterus transplant side, or 6 months, which is what we were using, 6 months to a year as a washout period. I'm not sure what others are doing. These patients, again, are asked to postpone pregnancy for 2 years and undergo a washout period for mycophenolate if they've been on it. They're generally then, if they're off of mycophenolate, on at least a calcineurin inhibitor. And I think tacrolimus is the go-to drug today. Maybe you, Dr. Zarmpar, would comment on that. But I don't change anything after the transplant team has also agreed that the patient can now try to conceive. So do you want to make a comment about that? Because again, I don't want to pretend to be managing these medications.
Yeah, so liver transplant's a little different from the other transplants in the sense that Liver is somewhat of an immunotolerant organ, not as immunogenic as kidney or lung or heart or uterus. And so we do get away with having a little bit lower immunosuppression, especially later on in the process. And so it's not unusual for us to have, patients on a single drug immunosuppression. And although depending on the patient's specific situation, it can be mycophenolate occasionally. Usually, if they're on a single drug, it's going to be tacrolimus. Now, that said, folks who have autoimmune hepatitis, for example, will not ever really be on single drug immunosuppression. But yeah, no, I think single drug tacrolimus is pretty common.
Yeah.
Now, that brings me to sort of a related question as to whether, we talked about immunosuppression and pregnancy and the fetus, but have you noticed anything specific about liver transplants versus the other transplants in this setting, or not enough data?
Well, I think, again, my experience is kidney, liver, and uterus, and more recently uterus in great numbers in the last couple of years. But let me say this about uterus transplant. The uterus is not HLA matched. The uterus is only blood type matched. And
right.
That's because it's a very short transplant, not anticipated to be in more than a few years. So as you mentioned, that alone makes it a little bit more predisposed to a potential rejection episode. And rejection episodes have been reported worldwide in uterus transplant, and they're managed with high doses of steroids, pulse doses of steroids to try to get control. You asked about, say your question again, related to the medication.
Well, yeah, so just, I guess, do you see anything specific about liver transplants as opposed to transplantation in general and pregnancy?
Yeah, and again, speaking with just a few in hand, no. And I don't have 20 patients or 10 patients even to draw on, just a few. And I haven't seen anything unusual in terms of the medical management. This is all done, again, with the hepatology team. They're seeing you guys regularly. I'm on the phone, and I haven't, there has been no issues, as you pointed out. Maybe this is fortuitous. Pregnancy, of course, is a condition, a life milestone that's associated with immunotolerance. And it may be that what we see with this patient population is not only the immunotolerance of pregnancy, but the tacrolimus single agent all working together to help us in terms of getting a successful pregnancy outcome.
That's actually an excellent segue into Dr. Wen's second question about a cystic fibrosis patient with a lung transplant who had rejection followed by a postpartum preeclampsia. Now he asks whether pregnancy increases risk for rejection.
Well, I don't have any data to say that it increases the risk of rejection, only in that sometimes the medications which kept the patient stable while they were not pregnant are modified, such as the mycophenolate. And if a patient really wanted to accept some risk, that risk would be of rejection if she wanted to forego the mycophenolate across pregnancy. The other thing that I can think about is if drug levels are not monitored carefully, because pregnancy does have an increased intravascular volume, all drug levels will be essentially diluted. We see this with anti-epileptic medications, where we have to really increase the medication dosage. And the metabolism is, of course, increased in general in pregnancy. And those would be the things to watch. Now, I put on there, is drug monitoring possible? And certainly it's not possible with some of the agents that are used. And it is possible, however, with calcineurin inhibitors, which we're fortunate to have. I was going to ask you if you try to keep people into a 7 to 10, I think it's milligrams per deciliter range or nanograms per deciliter range of tacrolimus. If 7 to 10 is your typical preferred drug level for tacrolimus during pregnancy in a liver transplant patient. That's what I've seen, but
Right.
under what you are looking
Yeah, so I mean, I think for the most part, if they're on single drug, then we do tend towards the higher end, 7 to 10, 8 to 10. Again, depending on how they've been doing, how many rejection episodes they've had, how far post-transplant they are, what their etiology was. But, single agent, generally higher levels. We don't, I mean, a lot of it is just, a lot of immunosuppression is just gestalt. I feel like this person has more tendency to reject, or I feel that this person is more at a tendency to have an infectious complication. And that's one of the things that we're doing research on. And I think that's one of the things that some of this donor-derived cell-free DNA work that is revitalizing evaluation for graft injury is headed towards. But it's clinical art as opposed to clinical science. With even when it comes to drug levels, how do we know whether a certain drug level is better, is the correct one? I think a lot of it's just gestalt.
What would be a good 2 minute, take 2 minutes to go over would be what we're using to monitor for rejection. And if it's simply liver function tests, we have to remember too that liver functions are up in all of these potentially up in all of these hypertension associated pregnancy conditions.
Right.
And it is really going to be challenging if we see these rejection markers rising in the second half of the pregnancy, particularly if there's any bump at all in blood pressure. So I like to keep the blood pressure down. And I'll treat, as I mentioned earlier, than what ACOG might recommend for a typical patient with gestational hypertension or even a preeclamptic patient in pregnancy. And I do think that in the preeclamptic population, certainly elevated liver functions are associated with higher blood pressures many times. So I try to manage that. Can you comment about any other markers that might be used for monitoring rejection other than LFTs?
Unfortunately, when it comes to liver, not really. So liver function tests, not just AST and ALT, but also alkaline phosphatase and bilirubin, GGT. I mean, these are all associated with liver injury, which in the case of a liver transplant is, can be a rejection, but it could also be ischemia, it could be drug toxicity, it could be a whole host of things. So, and even the newer methodologies, right, the donor-derived cell-free DNA is just liver injury. So it's not very specific to just rejection. Now, if we're talking about, kidney transplant, then it becomes a little bit more specific. Things that we are looking at, and actually this harkens back to the early days of liver transplantation, is that some, Starzl was apparently looking at EBV levels as a surrogate for how immunosuppressed someone was. Too high means, too immunosuppressed, too low meant not immunosuppressed enough. And so we are looking at some viral sort of measures of how immunosuppressed patients are. But again, this is all investigational at this point.
And I should, for the audience, just make mention that alkaline phosphatase would not be a good measure in pregnancy because of the high levels of placental alkaline phosphatase.
Right. Yeah. Very non-specific.
Very non-specific. And bilirubin would be. I mean, I think that would be the right thing to do. And you mentioned one other thing.
GGT.
Yeah, GGT. Yeah, and so GGT might also be helpful to us.
Right, it's a little bit more sort of biliary specific as opposed to non-specific like alkaline phosphatases.
Yeah. Well, this was great. There's maybe one more question I'm reading here. Are the preterm deliveries spontaneous or indicated relation to live transplantation? And it's an interesting and important question. And too often when people are are reporting obstetric complications. They don't separate preterm birth from preterm labor, and they don't separate indicated preterm labor, that would be from maternal, medical, or obstetric complications, from spontaneous onset preterm labor, preterm birth. So I don't have that because what I presented was information from the registries, and it's not broken down the way a maternal fetal medicine person would like it to be broken down.
Can I just make one more comment? I think, first of all, you're very modest. I think anybody who takes care of a quintuplets and a liver transplantation in the same pregnancy, boy, I think you're practicing at the top of your license. And I think you're also very realistic that how can you be an expert on a challenge like this? And I don't think there are any experts, and it's very difficult to do any kind of research. And of course, these are rare conditions, but when it becomes your patient, it's a real situation. Are there any, I mean, and most of the data you presented are from Scandinavia, from Sweden, where it's socialized medicine, and perhaps they have a better access to the population statistics. In the US, are there any registries where we can register these liver transplant patients during pregnancy so that we can gather some meaningful data? I mean, all the questions that we're discussing here, as as Dr. Zernpar said, it's mostly gestalt because, we don't have the data. Are you aware of such registries, or perhaps it's worth to create such registries?
I am not specifically aware of any, and we didn't report any of our patients to a registry. I'm sure UNOS and others in the liver transplant world are keeping some. We did collect, Baylor University Medical Center in Dallas is a large transplant center. That's why the uterus transplant program wound up sitting there. Not too long ago, at least I know that the department I was leading had a resident research project collecting years of uterus transplant and pregnancy outcome data. I didn't see that went to publication, but it's not an official registry. And maybe, Mehmet, we can talk about that, how one would start such a thing if there isn't one already, and there may be one with a little more research that I'm aware of. But it would be a fascinating thing to do. And I think you folks at the University of Florida would be perfectly poised to house that and get that going if there isn't one already going. But I'd be happy to put my 2 cents in if you're interested in developing such a thing. It's needed, and I think we're going to see more and more transplanted women. As I mentioned earlier, I think some of the outcomes aren't broken down the way that we would find them most valuable as maternal fetal medicine physicians in terms of counseling and providing patient information. And the more you break this down and learn, the more you can target what needs to be done.
Absolutely.
I threw out there that cervical length should be done on all of these patients. If we really knew this was spontaneous preterm labor and preterm birth, it'd be a no-brainer to do that. It might be a no-brainer to put people on progesterone if that were the case. But it's not talked about in the way that we need it talked about in maternal fetal medicine circles. So again, I think your institution, since you guys do transplant and have a vibrant transplant program there, it might be a nice place to house such a registry. Again, I didn't see one specifically devoted to pregnancy, but I could be wrong.
Great. Thank you very much, Dr. Gregg, Dr. Rhoton-Vlasak. and Dr. Zori had to step out a little early. This was a great set of talks. Thank you for taking the time to answer our questions. Thank you, Dr. Genc, for helping putting this together. And thank you, Ivory, for organizing all of this. There are no more questions. I think we can.
Thank you. Good night.
Bye, everybody. Thank you very much.
Thank you.
Bye-bye.
Bye-bye.
Thank you.
Bye-bye.